All right, so let's go ahead and begin our discussion on some of the radiographic things that you'll be responsible for as a respiratory therapist. So one of the first things we'll start with the different views. So obviously, X-rays are done to help get a look at what's going on internally inside the body. Specifically, you can see bone pretty well with X-ray. There's some masses that'll show up pretty well. If you got a mass that you suspect shows up on a chest X-ray, then they may actually look at ordering chest CT or something to that effect. Something that's going to give them a little bit better look than just what the standard chest X-ray is going to give. But with the chest X-ray, you've got the posterior anterior film that's typically done in the hospital or in the radiology department rather. It is the superior film in regard to the AP film, your anterior posterior film. The AP film's done on a portable machine. Not all patients can be transported down to the radiology department for a PA film. So AP films are done. You just got to understand with an AP film that your heart's likely going to be a little bit more magnified because it sits closer to the X-ray source. You can also have lateral films. Typically, the arms will be raised up so that those are out of the way so that it doesn't skew the vantage point. There's also the lateral decubitus film. For us specifically, the lateral decubitus film can be pretty advantageous when assessing the presence of a pleural effusion. You'll look for something called the meniscus sign. If you can remember from chemistry and even maybe biology, where you're looking at a graduated cylinder and you're measuring the volume in those cylinders, you've measured the volume at the level of the meniscus. So if you can remember that, that's what your meniscus sign would appear as such when you've got a lateral decubitus film, or if you got a pleural effusion, and that shows up in the lateral decubitus film. So if you had a right-sided lateral decubitus film, the individual would be lying on their right side while the X-ray is taken. If it's a left lateral decubitus film, the individual would be lying on their left side while the lateral decubitus is filmed. So you also want to make sure that you understand the overall technical quality of the films in which you're looking at. Some films may show up too dark or too radiolucent. If they're too dark, then they've been overexposed to the radiations or the X-ray source. If they're too light or too bright or too white or too radiopaque, then they've been underexposed. So as far as the overall technical quality of the film, you want to make sure. And with digital imaging these days, used to you take the actual film and put it up on the X-ray box and look at it. And there wasn't a whole lot to be done with changing the overall contrast. But with digital films, you can change the contrast a bit depending upon what X-ray viewing software that the facility that you'd be working in is going to be utilizing. So those are some things to think about. Some pretty cool things too that you can do with that digital software is actually measure the distance. For instance, one of the things we're going to be concerned with is distance between the tip of an endotracheal tube and the level of the corona. So we can go through that. And it's important to understand the different imaging techniques as well that you would be involved in, potentially having to take your patient to. So for instance, in my life as a respiratory therapist, I've taken patients to the radiology department. I've taken individuals to CT scanner. I've taken individuals to an MRI. I've taken individuals to the cath lab to go under fluoroscopy. I've been at the bedside while they've done ultrasounds, echocardiograms, all of those things. And it's important also to understand what puts off radiation and what doesn't. So general X-rays, whether it be portable or in the department, those put off radiation. CT puts off radiation, whether it's a regular CT with contrast, high resolution CT, all those put off radiation. Positron emission tomography, PET scans, a lot of times those can be done in conjunction with the CT if they suspect that a patient's got cancer. So those are utilized, or those utilize radiation as well. Fluoroscopy is a moving X-ray, so you might see someone going for like a swallow study or something to that effect, do something under fluoroscopy, or sometimes they may place lines under fluoroscopy if they're going to put like an intra-aortic balloon pump or a stent for a patient that's coming in for percutaneous coronary intervention, PCI. Those individuals a lot of times will undergo the procedure under fluoroscopy. So that puts off radiation as well. Then you've got MRI, ultrasound, echocardiography. Those items utilize, they don't emit radiation per se. So with the other items, you would want to make sure that you're wearing a lead apron and protect your thyroid pretty well. But the other items, don't necessarily have to have. The other, I will say, is another safety mechanism to implement with an MRI machine is it's a super strong magnet. So you want to make sure that you're not taking anything metal or anything that would be attracted to that magnet inside of that room, because the magnet could grab it uh, and get hold. And if there are other YouTube videos and stuff out there, if you care to look on the attraction of the magnet for an MRI machine, it's pretty hardcore. I can recall a time in which I went into a room with a patient with a nurse, and the MRI techs are pretty good about having you clear any metal or what have you got on your body. And we did, or so we thought. We went into the room, and the nurse that I was with, her hair started wiggling, and kind of like didn't know what the deal was. She had put bobby pins in her hair, so those bobby pins, whatever material they were made out of, were attracted to the magnet. So she didn't get close enough where the magnet yanked them, but we got close enough to where they started moving on her head. So she backed up and was able to take the bobby pins out before we got started. Different tissue densities that you'll see. So things that show up more shades of gray or white are going to be considered radiopaque, and things that are darker or blackened, if you will, are going to show up more radiolucent on a chest x-ray. So now that we've gone over some of the basics, we'll go ahead and just kind of look at some of these x-rays and see what we would like to be able to see as a respiratory therapist when we're in the unit. So if you can remember from like where you're going over your inspection, palpation, percussion, auscultation, we're very involved with symmetry of the chest, making sure we've got equal and bilateral movement of the chest. We're concerned if we see unilateral movement. We're concerned if we've got diminished breath sounds on one side versus the other. So when we're looking at a chest x-ray, there should be, and this particular image doesn't show it, but there should be some type of tag that lets you know that you're looking at the patient's, that it's oriented appropriately. So there should be an R on one side to let you know it's the right side, or an L on the other to let you know that that's the left side. So when you orient this, the patient's left is going to be on your right. On a properly oriented film, the patient's left is going to be on your right, and the patient's right is going to be on your left. So you can see that the ribs, and you got significant areas of whiteness over here on the right lung. So you can see the contrast between the right lung versus the left lung. This particular patient actually has a massive amount of atelectasis and a right-sided pneumonia. So that atelectasis is going to cause consolidated lung tissue. So if you can remember from inspection, palpation, percussion, auscultation, on inspection, this patient's likely going to have unilateral chest movement. The left chest wall is probably going to move better than the right chest wall. They're going to have diminished breath sounds on the right side because they don't have as much aerated lung tissue as they do over here on the left-hand side. If you were to do your percussion techniques, remember where you're striking the distal interphalangeal joint up against the thorax of the chest, you're going to have dull percussion notes on the right side of the chest where you should have normal resonant tones over here. So inspection, palpation. And then if you're going through and doing like your tactile fremitus, where you're placing your hands along the thorax and having them say 99, 99, 99. You should feel normal fremitus over here, but you're likely going to have an increase in tactile fremitus over here, because this consolidated lung tissue gives a medium for the vibrations of that 99 to be transmitted to the chest wall. So some things we'll talk about too is tracheal deviation. When you're assessing your trachea, the trachea should be midline, and you typically do that by taking your two fingers and running that down the trachea through the suprasternal notch to make sure that everything's midline as best you can tell there. So looking at this particular x-ray, your trachea, you can see, and I'm going to trace it for you. Your trachea has a bit of a sigmoid shape to it, and you can see the right bifurcation and the left bifurcation, with the actual carina being right here. So the bifurcation of the trachea is the carina. Uh, Remember from your pathophysiology course, there are diseases that will cause the trachea and the mediastinum to pull toward the affected side, pull toward the pathology, or pull toward the disease. And then there's also pathology or instances in which the trachea may be pushed away from the disease, pushed away from the pathology, or pushed away from the affected side. So if you can remember, atelectasis, consolidation, pneumonia, and pathologies similar in nature to that are going to cause a mediastinal and tracheal shift toward the affected side or toward the disease, toward the pathology, as opposed to where a pneumothorax, hydrothorax, chylothorax, uh, pleural effusion, um, tumors, or anything to that effect would cause the trachea to move away from the affected side. So if you remember that from your pathophysiology course, uh, basically what we're looking at here is a tracheal shift, and this tracheal shift is due to the increase in opacity that we see over here, and the increase in opacity is due to atelectasis, consolidation, and likely pneumonia that this patient's got going on. So that's what we see here. That trachea should be more midline. So the trachea you should see pretty much like I'm drawing it here as you would move through. But the true trachea, as I've outlined here, you can see has a sigmoid shape because that should be straight up and down. A couple other things when you're looking at the overall quality of your film and things, some things to keep in mind. You want to make sure that you can see the clavicles, because the clavicles are going to give you an indication if the patient's rotated or not. Those clavicles should be pretty straight across. If they're not straight across, if one happens to be higher than the other, the patient's rotated. As far as the overall underexposed, overexposed, you should also be able to see the spinous processes through your first couple of thoracic cervical vertebrae as well. Some anatomical structures that will pinpoint. So we've gone over the clavicles as well. You can see the heads of your humerus. Over here, you can see the scapula shadow. You've got to be careful. You can see that this patient's got their arms moved. So you don't want to confuse the shadow that would be formed by the scapula as any kind of pneumothorax or anything to that effect. So you want to make sure that your vascular markings that you can see throughout the your vascular markings that you can see extend all the way out to the chest wall. If you actually look close enough, one thing that we can see here, you can kind of see some distinct lines here. So those may actually be your bronchograms, if you remember reading about those. When you're counting your ribs, make sure that you understand that the anterior and posterior ribs are going to be seen on the chest x-ray. So don't count the same rib twice. So, you could count closer to the spine if you wanted to. You could come out here and actually count you could count the, all right, so you want to make sure that we can pick out the ribs. You don't want to count the same rib twice. So you can be, like I mentioned, either by the spine or you come out here on the side and where you'd see that it would curve, count your ribs as they go down. Be able to pick out where your diaphragm's at. So if we're looking at the diaphragm, I'm going to kind of trace the diaphragm. It's a nice dome-shaped muscle that shows up. And make sure when you're looking at your x-ray, you can see the entire chest on the x-ray. So you also notice that this diaphragm here, and I'll finish drawing where, and I'm a little off because you can see some of it above here, but nonetheless, it comes to the rib cage. So where your ribs meet the diaphragm, you've got an angle that gets created there, and it's called the costophrenic angle. That's you wanted that to be kind of nice and sharp. If it happens to be doled out, blunted, or obliterated, or anything to that effect, atelectasis, consolidation, pleural effusions, things of those natures can cause that to not be nice and sharp. So another thing that's not necessarily seen here, but you should be able to make out a gastric air bubble within the x-ray as well. However, like I said, not necessarily seen in this particular. And the heart, you can see the right main stem bronchus here, the left main stem bronchus, and the heart kind of disappears a little bit with all the consolidation, everything we've got, but you can also tell the mediastinum has been pulled over. But your heart typically should be not necessarily a boot shape, but if you think of a pear or something to that effect, you've got the apex of the heart down here. So the apex should be oriented toward uh, the left portion of the heart with the base kind of sitting back here, and then you would have the aorta and stuff that comes up off that. So you'd be able to see the aortic knob or the aortic arch as we're moving through that. So again, those are some things we should be able to pick out, and we're kind of implementing our inspection, palpation, percussion, and auscultation as we move, or trying to implement that as we're talking about things as well. So I'm going to clear this, and then we'll clear that, and then we'll move on to the next image. All right, so looking at this particular film, you can see that as far as exposure, it looks to be pretty good. You've got your spinous processes that you can see down through. You've got vascular markings that extend all the way out to the chest wall. You've got a nice dome-shaped hemidiaphragm. So you've got your left hemidiaphragm over here, right hemidiaphragm over here. You can see your aortic arch in this area. You can see the trachea, the bifurcation to the right main stem bronchus, the left main stem bronchus. One thing that I didn't mention on the last x-ray that we wanted to look at is where the airway and blood vessels enter into the lung. That's going to be called your hilum or hilar region. So you want to make sure that you pay attention to that. You can see the gastric air bubble down underneath the diaphragm here. So that's good costophrenic angles, good aerated lung tissue. One thing that's a little different on this chest x-ray than it was before, so the clavicles are fairly well straight across. Doesn't appear to be too much rotation in there. And we got a little tag to let us know that the patient's, this is the patient's right over here. So we'll also see that the heart, remember I told you the heart should be oriented with the apex pointing toward the patient's left. The apex of this heart's actually pointed more toward the patient's right. So this patient's got a condition called dextrocardia, and that's where the heart's actually mal-rotated, mal-positioned, so that's turned the other way. So your apex points the more toward the opposite side of the way in which it's supposed to be going. So we'll go ahead and go on to the next image. Now, if we look at this particular chest x-ray, and you want to make sure that if you're working in the ICU, I mean, you really should be assessing your patient's chart every day, looking at the chest x-rays every day if there's one done daily, because you want to be able to see if there's anything new going on as far as their lungs are concerned. So when we look here, one thing we will say right off the bat is we don't see the entire chest on this particular chest x-ray. So it would be nice to be able to see the entire chest so we can get a good look at the hemidiaphragms, the costophrenic angles, and what have you. We can tell with the pathology that we see going on here with this increase in opacities of both sides. So you've got a potential for the increase. We got infiltrates, atelectasis, a consolidation that shows up on both sides of the lungs. So you can imagine you're probably not going to have those nice sharp costophrenic angles like we had talked about. This lets us know that it is a portable AP. This is the right side of the patient over here. But we do see a couple of things so you can make out the heart. You can see the heart is oriented just as it should. The aortic arch, aortic knob. You can see the trachea. The trachea bifurcates into your right main stem bronchus, the left main stem bronchus. So we're looking at our hilar region here. The carina, I'll put a dot right on where the carina is at. The carina is there. Hopefully you can pick that out. Another item in this particular chest x-ray that we've not seen just yet, you've got these electrodes that are on your patient, and then you've got the lead wires. So you've remember going over ECGs. So these are going to be the items in which create the leads, or part of the electrodes that would look into creating your standard limb leads 1, 2, and 3 as we work through there. But if you'll notice this heavy white line that you see right here, and I'll try to trace it, this heavy white line, that's your radiopaque line on your endotracheal tube. So this patient has an endotracheal tube. You can also see that you've got your pilot tube or pilot balloon right here. So you can see these little circles, that's a spring-loaded valve. So you'd actually insert your syringe here and inflate the cuff, because this endotracheal tube has a cuff on the end of it. and that cuff is going to be inflated with air to seal off the trachea so that the air is only moving in and out of the lungs by way of the airway or the endotracheal tube that you've got placed in there. Another thing that probably sticks out is you see this little line that comes in through the neck right here. That's most likely a central line that would end up the right atrium, letting you know that way you can get your CVP or right atrial pressure off of that. As with anything that we do in respiratory therapy, be systematic in your approach. Several textbooks recommend starting from the middle and working your way out. Just be systematic in the way that you decide to do it. That way you don't happen to overlook something. So we'll see another chest x-ray here. This other chest x-ray, you can tell the patient is intubated. You can see that there's an endotracheal tube here, and that endotracheal tube terminates about right here. You can make out the carina down here. So your carina, the distance between the tip of the endotracheal tube and the carina should be roughly 3 to 5 centimeters per the NBRC guidelines that we've gone over. So when you're studying for your TMC exam, remember tip of endotracheal tube should be 3 to 5 centimeters above the level of the carina. Another thing that we're looking at in this particular film, so you can see the hemidiaphragms and so forth. You also see these little, these are the sternal wires. So this individual's had open heart surgery or coronary artery bypass grafting surgery. So those are the sternal wires that they place to put the sternum back together. And another item that we can see here that we've not seen just yet is, if you see this line, so we looked at a central line earlier, but you've probably remember, if you've done any type of hemodynamics or anything to that effect, can remember the Swan-Ganz catheter. Swan-Ganz catheter, your pulmonary artery catheter, the balloon tip, flow directed catheter. Those are all terms that may be utilized on the TMC exam when you go to take that. But you got your balloon tip, flow directed catheter, and this is where you would get, so you get your CVP off of that. But you'll notice that it enters through the right atrium into the right ventricle, goes up through the pulmonary artery, and that's where it's going to sit in the pulmonary artery. So there's a balloon on the tip of this catheter that can be inflated, and that's where you're going to get your pulmonary capillary wedge pressure. That can also be called your pulmonary artery wedge pressure or your pulmonary artery occlusion pressure. So if you're looking at the abbreviations for those, PCWP, PAOP, or PAWP, pulmonary artery occlusion pressure, pulmonary capillary wedge pressure, or pulmonary artery wedge pressure. So we'll go ahead and clear my drawing here, and we'll move forward to the next one. Over here, we see some things that we've not seen just yet, and it definitely is visible, especially if you've looked at these. I mean, just your clavicles are straight across. You've got aeration of both lungs. However, you notice the vascular markings extend all the way out to the chest wall over here, but they do not extend all the way out to the chest wall on the patient's right-hand side. You got your gastric bubble here, your hemidiaphragms. You can make out the spinous processes throughout cervical and thoracic vertebrate. You can see your trachea, find the bifurcation, your left and right main stem bronchus. You can also see the aortic knob or the aortic arch. The heart's oriented in an appropriate position. But one thing that we'll look at here, and you remember I told you if the arms aren't moved out of the way or positioned in such a way, you can see a distinct line on that scapula. Sometimes that can make you think that you're seeing a pneumothorax, but the fact that you see these vascular markings extend all the way out to the chest wall lets you know that there's not a pneumothorax there. So you're looking at the scapula. So that scapula, I'll trace it for you. Kind of makes a triangle, if you will, so you can see that scapula there, and that's what we're looking at in that particular area. But if you'll come over here on the patient's right hand side, you still got some scapula shadow over here, but notice these vascular markings stop pretty much right there as well. So, and you can see this distinct line that shows up through this area, and there's a little bit of space in between those lines there. So you've actually got your scapula shadow there, but the distinct lining of the pleural line in there that you see of the lung. So we've got an increase in radiolucency here. So that lets us know that we've got a pneumothorax on the right-hand side. You might be seeing a little bit of deviation of the trachea to the right side in this particular room. But if air continues to collect over here and this becomes under a tension pneumothorax, then with that being a tension pneumothorax, you would see a mediastinal shift away from the affected side. So everything would move over toward the left side. And if it became under tension, what you would want to do, if a surgeon or what have you wasn't there immediately to insert a chest tube, or physician wasn't there immediately to insert a chest tube, and you're checked off to do this within your facility, you could do needle decompression of a tension pneumothorax. And basically what you're going to do is you would place a 14 gauge angiocath in the second intercostal space in the midclavicular line. So as far as your palpation, this is where your palpation, percussion, auscultation stuff comes into play. So if you were going to, and I'll turn the video on so you guys can see what I'm doing. But if you're going to palpate, you're going to find your suprasternal notch. With your suprasternal notch, you're going to come down to where the over the manubrium, and then you get this little outward protrusion. That outward protrusion is going to be your angle of Louis. If you slide out from the angle of Louis, that puts you directly over the second rib. So if you're directly over the second rib, that means the rib on top of that should be your first rib, and that would be your first intercostal space. So then if you take your fingers and just kind of rock down the chest wall, you find your second intercostal space, line that up with your midclavicular line, and you would want to make sure that that's where you stick your needle at. Now, if these are those ribs, so if this is rib 1, rib 2, and rib 3, with this being the first intercostal space and this being the second intercostal space, you would want to make sure that you stick that needle in just over the top of the third rib as opposed to just underneath. Now, yes, granted, going underneath or over the top puts you in the second intercostal space regardless of where you're at, but you've got to remember that blood vessels and nerves run in that costal groove underneath the rib. So if you stick a needle just over the top of the bottom rib as opposed to just under the top rib, then you're less likely to hit any of those vessels or nerves. So go directly over the top, and you're going to insert that till you hear a rush of gas come out. I'll turn this off and we'll get back after it. We can also see the reason for this pneumothorax as well. You've got rib breaks right here. So you see a break there, break there, break there, maybe a break there. Now, if you remember flail chest, where you get the paradoxical movement of the chest and so forth, because if you remember, I'll turn the camera back on. If you remember, your lungs have a natural tendency to want to recoil inward. So they always want to recoil inward, and then your rib cage has a natural tendency to want to move outward like that. So, and then we also know when the diaphragm contracts, it creates a negative pressure. So you have your pressure gradient so that you can breathe and all that other good stuff where we're talking about. But ultimately what happens with a flail chest, when you've got the double breaks on those adjacent ribs, then there's no continuity of that rib cage. So as far as the rib movement, so when that negative pressure is generated from the diaphragm contracting, it will actually cause that portion of the chest to cave in as opposed to expand like it's supposed to. So let me turn that back off. And that's all I'll say about that. Clear the drawing and we'll go ahead and move on to the next one. I don't want to keep you too terribly long, but there's a few more that I want to go over. So a CT is pretty cool in that it allows you to have closer looks at pathology or whatever that you might see going on. So I'll just draw a stick figure. So if you've got a stick figure patient, they'll be lying in the supine position. And ultimately a CT, what it does is it takes images, slices of their body. So it basically slices them up, and ultimately what happens is as you transition through this, it would almost be like you're standing at the foot of the patient, and you're looking at them from an inferior view to their head. So ultimately when we look at either one of these CTs, this is the patient's back and that's the patient's back. So if this is the patient, then this is going to be the patient's right lung. This is going to be the patient's left lung. Patient's right lung, patient's left lung. Now, both of these have relatively healthy looking lungs, normal lungs. So I wanted to show you that for the purpose that you might have take somebody to CT for that. You might even take someone for CT angiography if they're assessing for pulmonary embolism or anything of that nature. So just keep that in mind. And if you ever go on a transport in the hospital with an intubated, mechanically ventilated patient, always take a bag valve mask, and a mask with a bag and valve and a mask with you, because if the patient becomes extubated, you want to make sure that you can manually ventilate that patient. So always take a bag and a mask with you. And I would make sure I take a self-inflating mask, a self-inflating bag with me, because if I take a flow inflating bag and I didn't check the pressure on that cylinder before I left and the cylinder runs out, pretty much SOL at that point. Make sure you take a self-inflating bag with you, because at the very minimum, if your O2 cylinder would have run out and transported, you got stuck on an elevator or something, and that happens. I've been stuck on elevators with patients before. With a self-inflating bag, I mean, although you'd like to have 100% when you're breathing for somebody, with a self-inflating bag, you can still ventilate for them with atmospheric air or 21% oxygen. So both of these people present with relatively healthy looking lung fields, but would like you to notice when we're talking about like lung compliance and stuff to that effect. And remember, compliance is the ability of the lungs to receive volume. You can tell based upon the difference in radiolucency and radiopaqueness that the patient on the right-hand side of your screen versus the patient on the left-hand side of your screen, there's more adipose tissue on the right-hand side. So you would have more pressure on the chest, so you would have a decrease in chest wall compliance over here because of the extra weight of this adipose tissue is going to kind of hold that down. So you can see the heart, the spinous processes. So this is going to be the back, and again, you orient yourself from the feet looking toward the patient's head. So let me clear that and we'll move forward to the next one. This particular patient's got scoliosis. You can see the curvature of the spine. You also can probably imagine how it might be difficult to ventilate one of these individuals, especially if they were to become problematic with the side that's impacted or restricted, if you will, based upon the anatomical alteration of the spinal column. And then we'll finish up with this particular chest x-ray. This is a normal chest x-ray. It's oriented appropriately. You can see that your clavicles are pretty well straight across. So some things that we should be able to pick out, you should definitely be able to pick out whether or not there's a tracheostomy tube or an endotracheal tube. This is your normal spontaneous breathing patient, so we don't see that. So you want to make sure that you can pick out the clavicles. So your clavicles here. Spinous processes should be seen. You can see that. So this kind of like hollow tube that we see here that's more radiolucent than radiopaque, you can see the outline of that. That's your trachea. This item right here is your carina. Got your heart, a rib, costophrenic angle. Got your gastric air bubble. Gastric bubble. You've got your right hemidiaphragm. Let's see here, the scapula's over here, and you got them on both sides. I'm just picking out one. This area here would be your hilar region or hilum, and then you've got to be able to visualize the anatomy. But this little bump that you see right here, your aortic arch or your aortic knob. And those are some things that we should be able to pick out. And then obviously, if you've got anything different, whether it be a pneumothorax, atelectasis, consolidation, we should be able to see that any increase in opacity, you probably have some pulmonary nodules that could show up, especially if you've got a patient that might be, being evaluated for lung cancer or anything to that effect. Definitely be able to pick out your airways and so forth, and your lines. Another thing I didn't mention just yet, we got the radiopaque line on an endotracheal tube, but sometimes you'll see a tube that comes down and it goes to the stomach. That would be your nasogastric tube or your orogastric tube. So an NG or an OG tube, those have a radiopaque line on them too. And you should, the x-ray should be assessed on those, because I had a patient one time that I was doing tracheal suction on. They had an endotracheal tube, so I was doing inline suction with them, and I started getting back what looked like tube feeds. It was a lot of tan stuff. after checking the x-ray, when they had dropped the NG tube down, that tube had actually made it slip past the cuff, went into the trachea and coiled up right there below the tracheal tube. And they turned the tube feeds on. They were filling the lungs full of tube feeds. So you got to be careful with that. So with this, we'll go ahead and wrap things up. Thank you for your time and attention. I hope you all have a great day.